Hello and welcome to this Royal Society of Medicine webinar series on the health emergency of climate change. In this fourth episode of a series, we'll be focusing in on the impact of climate change on cardiovascular health. My name is Ali Yazdi. I'm a cardiology ST3 registrar at Royal London Hospital. I'm delighted to be your host for the next hour or so, and I'm very grateful to the RSM for involving trainees in this debate and for putting together a really impressive list of resources for anyone wanting to find out more about this issue of climate change and health. And the profile of the issue is growing. Extreme weather is becoming more common. Average temperatures across the globe are rising. And this is down to human activity and accumulation of greenhouse gases. We're going to hear today about the evidence that this change in weather is already impacting on our hearts and circulatory systems. It's causing morbidity, mortality, death and suffering that perhaps hasn't received the attention that it deserves, particularly because there are things that we can do to change course. We're very fortunate this evening to be joined by experts in this area, two pioneers in their field who will be speaking to us about the background to the topic and what we can do about it. Professor Annette Peters, Director of the Helmholtz Center in Munich, will firstly discuss how climate change will impact on cardiovascular health, and she'll be followed by Dr. Leslie Cho, Professor of Medicine at the Cleveland Clinic Lerner College of Medicine, who will then go on to discuss the significance of this impact in terms of cardiovascular disease prevention. We'll then move on to panel discussion, where we'll be having a look at your questions posted during the session. So please do post your questions using the Q&A function. There are about 300 or so of you tuned in at the moment. I know a fair chunk of you will be students and trainees such as myself, so we welcome questions from anyone, but particularly anybody within that demographic who has a particular vested interest in this topic. I'm delighted to move on to our first speaker, Professor Annette Peters, Director of the Institute of Epidemiology at the Helmholtz Center in Munich, a research center for environmental health and part of the Munich Heart Alliance Center for Cardiovascular Research. Professor Peters has a long-standing interest in unpicking the role that our environment has on complex diseases, and she's pioneered work linking particulate matter to cardiometabolic diseases. She's helped us to find answers to the question of how pollution affects our hearts. She joins us from Germany. Professor Peters, thank you so much.
Dear Ali, many thanks for the kind introduction, and I would like to thank the Royal Society of Medicine for inviting me to present to you how climate change impacts cardiovascular diseases. And indeed, climate change drives global warming and makes heat events much more frequent. It also increases air pollution concentrations, and as our population is also changing, we're aging. We have also increasing disparities around the globe with socioeconomic burdens, and even though we live longer, we also accumulate more diseases. And I would like to highlight how this chain impacts our cardiovascular health. And so when we look to daily changes in temperatures, here you see an analysis of the London, UK. You see that temperature range between below freezing up to maybe above 25 degrees. So London is not a very hot city. However, you see if it gets unusually warm, you have a steep increase in the risk for mortality on a daily basis. And similarly so, there is a minimum mortality temperature, which is actually in London around 19 degrees Celsius. Below that number, the mortality also increases, but slowly. And then if it's very extreme, it starts to also increase substantially. So it's indeed the heat impacts which are of major concern within Europe, but also around the globe. And medically, there are the conditions of heat stroke and heat exhaustion. And heat exhaustion is the minor form where our body tries to abate the direct heat impacts, where we still sweat and we try to compensate and keep our temperatures low. However, if the heat is further increasing, we also can develop severe hyperthermia and dehydration, and have high body temperature, hot and red, and also dry flushed skin. And this can turn into very severe conditions, coma, and death. And these actually heat-related deaths, if you look to the death certificate, either in the UK as well as in other countries, they are actually rare. Most people who die during heat episodes are coded as cardiovascular death. And so let's visit one of the major episodes we had during this century, namely the 2003 heat wave. It had its center across in France, where you see comparing the July average temperatures or daytime surface temperatures in 2003 with 2001, you see that especially in southern France, you had highly elevated temperatures. And indeed, there the death toll was highest with for example, reporting really high death tolls in France. But you see also in the UK and Ireland, unusual, very hot temperatures were spotted, and also up to the very north. And these temperatures were also contributing to the rises in mortalities, which I had shown earlier. So if we zoom into this episode, and to Paris, France, you see here the temperatures in the black dashed line in 2003 compared to an average mean temperature at the same dates between 1999 to 2002. And you see that in this August period, there was a steep rise in temperatures, and which was sustained over a long period of time. And down here, as the bars, you see the daily deaths counted in Paris, France. And again, you see the average numbers of deaths in the period outside the heat episode. And then the 2003 data. And it's quite notable that also in other times when it turned warmer, you see these peaks in mortality. However, they were accumulating during the heat episode. And then there was this kind of really like breakthrough of the mortality. So after an extended time, it seemed that the population and the vulnerable people within the population were really kind of giving up, and mortality tolls were rising. And so under these extreme conditions, we see these severe events. However, we can also see that the drifts in temperature, which we currently observe, also are, for example, able to trigger a myocardial infarction. And this is now data from the myocardial infarction registry in Augsburg, Germany, which is a mid-sized town which is quite well ventilated. If we looked to myocardial infarction registry data on a daily basis before the century, we could see the cold effect as shown for mortality, and there was actually no sign of heat. If we then look at 13 years of data in this century, the myocardial infarctions due to cold were actually decreasing, whilst we now, even at temperate climates, could see a relationship between triggering of myocardial infarctions and heat, even still at modest temperatures. And when we looked into who were the vulnerable persons, we found that the heat effects were mainly seen in individuals with diabetes or with a history of hypertension. So here you see the relative risks associated with this heat arm, comparing the period before this turn of the century and after. And you see the statistically significant differences for these persons who experienced a myocardial infarction and reported a history of underlying disease. And so another area of concern are potential interactive effects between heat and air pollution. You may imagine that increased heat also increases our energy demand and potentially also will increase air pollution. And also there's the link to the forest fires, which again will increase air pollution concentrations. So what do we know about that? This is an example of an analysis in 25 cities in Italy, where the authors divided up the data into days with high air pollution during the summer, medium air pollution, and low air pollution. And they analyzed this in northern Italy, in the center of Italy, and the south, where the temperatures are generally higher. And they could consistently show in all three regions that a 1 degree, so an increase in temperature, was more associated with mortality when it was also a polluted day. And at relatively low concentrations of pollution, this was not statistically significant in the regions. However, if you sum up over entire Italy, there is also a temperature effect, but it's more pronounced if the air is polluted at the same time. So what are the underlying mechanisms linking heat to cardiovascular disease? So when the body is no longer able to control its body temperature due to excess heat, we talk about heat cytotoxicity, where cell damage by thermal and chemical stress can occur. There is a breakdown of the lipid membrane of our cells, and also the energy metabolism is breaking down. As a consequence, cell death may be occurring at organs affected of the heat stress, and this will also be activating the immune system and give a systemic signal to the entire body. There is evidence that hyper or hypocoagulation will occur. And remember this, one of the first slides I showed where discussed heat exhaustion. So at the time when the body is trying to abate the thermal stress by sweating, during this period, we may experience hypocoagulation. However, when then it becomes more severe, we observe hypercoagulation, and thereby through this mechanism will contribute, for example, to ischemia. But this is not the only way how ischemia, for example, can be of increased concern. There's also oxidative stress observed in response to heat cytotoxicity, but also independently with this increased stress level of the body. And it has been noted in panel study with repeated measurements that indeed circulatory inflammation is upregulated. There's also blood pressure dysregulation noted, and there is, besides the ischemia, which may be a consequence of inflammation or hypercoagulation, there's simply also the blood shunting, where the blood is shunted to the periphery and the heart is no longer able to really keep up the circulation, which also introduces ischemia at multiple organs of our body. And also, there is heart rate dysregulation and arrhythmia observed. And you may see now how even at moderate concentrations, an onset or a trigger for a myocardial infarction may occur, and what may be the underlying mechanisms which leads in extended heat periods then to this increased spike in mortality. And indeed, we observe multi-organ damage in these heat-related deaths. And so why is this important? So this is data comparing summer temperatures in the Northern Hemisphere between the 50s and 1980s. And if we look today in 2005, 2017, we really see a shift in the distribution. So what does it mean for a city like London? So going back to the figure I started the presentation with, you see these kind of two arms of the figure. If we now look, what are the forecasts under the no action scenario? You see that the temperatures are shifting. So the gray curve are the temperatures now for 2010 to 2019. And then the predictions from a climate scenario with no action, business as usual, would shift both the winter temperatures as well as the summer temperatures. So that may actually not look so dramatic, but if you now look what is happening to mortality, you see indeed there is a decrease in wintertime mortality, which is a benefit. However, there's also this overall increase in heat-related mortality, which is really substantial. So these are now evidence which is put forward around the globe, and which shows that with abatement of climate change, we can also abate the heat-related impacts of on cardiovascular disease. And given that we are now in the pandemic, we think it's important to also highlight that if you look at those who are vulnerable to heat, namely those people with social isolation, of low socioeconomic status, and exposed to urban air pollution, and look at the risk factors for severe COVID-19 disease and death, which are aging, pre-existing diseases, such as cardiovascular diseases, respiratory diseases, and diabetes, as well as exposure to air pollution, we fear that potentially with the pandemic and co-heat exposures and maybe reoccurring pandemics across the globe, we have additional interactions and additional synergistic effects. So we have today evidence, that heat exposures have severe cardiovascular disease health impacts, and that age, health status, and socioeconomic status are adding this vulnerability. We have also independently evidence since decades on air pollution health effects, and these are also likely to increase due to population aging. And we see interactions, and so that we will have, we fear that there are long-term health impacts. However, these interactions are also a tremendous chance, because if we abate climate change, we will also reduce air pollution, because the low carbon economies produce much less air pollution. So that this can also turn into a tremendous health benefit if we, for example, achieve the goals set by the Paris Agreement. So we expect that climate change will significantly contribute to individual risk as well as population-wide burden to cardiovascular disease. And we think that there is a tremendous chance to abate both. Thank you very much.
Thank you, Professor Peters, for that really clear summary of how climate change will affect cardiovascular health, and for bringing it close to home with that business as usual graph for London. And one can only speculate on how that will affect acute admissions across hospitals in this country and others, and pressure on healthcare systems if we do continue with business as usual. Please do keep your questions coming through. Our panelists will have a chance to answer them after our next speaker, so keep them coming on the Q&A function on the Zoom if you would please. I'm delighted to be able to move on to introduce our next speaker, Dr. Leslie Cho. Dr. Cho is Professor of Medicine at the Cleveland Clinic Lerner College of Medicine, Section Head of Preventative Cardiology at Cleveland Clinic, Director of Cleveland Clinic's Women Cardiovascular Center, and also a clinician, interventional cardiologist, and an educator, a leader in the field of cardiovascular disease prevention, and we are delighted to have her join us this evening. Dr. Cho, welcome.
Thank you so much. I am delighted to be here. I want to thank the Royal Society of Medicine for inviting me. I wish I was with you in London, but this is just as good. And I really want to spend some time talking about what does CVD prevention have to do with climate change. And, you know, Wendell Berry is a very famous poet, but also a farmer and an activist. And this is one of my favorite quotes from him. And he says, "The earth is what we all have in common." And I think that this point has been really brought to bear in the era of COVID-19. We used to think these outbreaks occur in some corner of the world and had no impact on us. But of course, now we know that we are all linked, that there is no isolation. We're intimately connected to one another. You heard from Professor Peters about cardiovascular disease and climate change and how extreme weather, whether it's cold or hot, can increase cardiovascular disease, heart attack and stroke, and air pollution can also cause the same. And we talk incessantly about zero emission. But when we look at global greenhouse gas emission, 1/3 of the gas emission comes from what we eat. And I'll talk about that and we'll go into that. But it comes from how we use the land and the agricultural production and our waste and whatnot. But that's an astounding figure that 30% of the global greenhouse emission comes from food. When you drill down to really the food, it's really beef and dairy that really has the tremendous impact on greenhouse gas emission. The way the land is used by cutting down, Amazon or cutting down trees, and of course the gas that's produced by the animals and how we farm them. I mean, it's a tremendous amount. And if you look at some of the other protein sources, for example, fish or eggs or rice or wild caught fish, it's really much less. So it's really beef and dairy and lamb that makes the big impact. If you look at this map and you look at this map of how much meat countries eat, and if you look at the US, which is where I currently live, it's about 122 kilograms of meat per person that someone is eating in 2017. That's astounding. I mean, let's just let that number sink in for a second. That's ridiculous. If you look at the UK, it's around 88 kilograms per person in terms, and the 5% of the population is vegetarian. So if that's the case, then, oh my God, there's somebody eating a lot of meat. So if we really change how we eat, can we impact carbon emission? And this is a data that was produced by the Oxford group. And if we do business as usual, it's, nothing's going to change. But if we really change the way we eat, eating less meat, eating less dairy, we can have a tremendous impact on carbon emission. And obviously, if we go to vegan, we can have an enormous impact. So diets for sure can impact the environment. But I want to spend the rest of the time talking about what is the data on cardiovascular disease prevention and meat consumption. Because I'm a clinician, I'm an interventional cardiologist who heads the section of prevention. And when I think about climate change and the infighting between countries and the different industries, you know, having very selfish goals, and as a clinician, what can we really do? But really, each individual clinician can have a tremendous impact because we talk to patients each day, and we can talk to them about our diet or their dietary consumption. So I'm going to just talk to you about diet and CVD, and this is a very good a meta-analysis of looking at various different food components and increase in mortality. So if you look at, this is meta-analysis of 7 studies looking at patients of consuming processed meat, and there's a tremendous increase in cardiovascular disease. Less so if you consume fish and fruit and vegetable, you actually have survival benefit if you eat whole grains and nuts and vegetables. If you replace just 1 serving a day of total red meat, just 1 serving a day of total red meat with other sources of protein, this is based out of the health professional study, 43,000 patients. If you just change that 1 serving of red meat to, let's say, even low-fat dairy or nuts or soy or plant-based protein, you can have a benefit, a survival benefit. Replacing unprocessed red meat, 1 serving of unprocessed red meat also has an impact on cardiovascular disease. If you replace processed red meat, you have a much greater impact in terms of cardiovascular disease. Now, let's say you substitute with plant protein, the things like processed red meat, unprocessed red meat, even chicken. Look at the impact you can have on all-cause mortality. This is from Nurses' Health Study and the Health Professional Study. This is around 131,000 patients. Look at the tremendous amount of benefit you can have substituting plant protein for processed red meat, unprocessed red meat, chicken, and even fish. This is substituting plant protein for just cardiovascular disease mortality. Again, a tremendous benefit in terms of substituting plant protein with processed red meat, unprocessed red meat, and even dairy. You can even impact cancer. And there's actually some data about impacting dementia as well with substituting animal protein for plant protein. Now, this is looking at different diet and cardiovascular disease. The Western diet, which is the diet that's common in Europe as well as in Americas, that's a diet that's heavy in meat as a source of protein, obviously increased risk for, of cardiovascular disease. But the DASH diet, which is a diet that's low in sodium and high in vegetables, the alternative healthy eating index diet, and the Mediterranean diet, a tremendous benefit in terms of reduction in cardiovascular disease. Look at the Mediterranean diet here. 13 studies and showing this amazing decrease in cardiovascular disease. Mediterranean diet has been shown in both primary prevention as well as secondary prevention trials to lower mortality for cardiovascular disease. That's tremendous. And of course, Mediterranean diet has also been shown to be beneficial for brain health as well. So cardiovascular disease prevention diet, a plant-based Mediterranean diet, helps patients have less cardiovascular disease, makes them live longer, makes them have less cancer, and it's actually good for the environment. So if we can't appeal to the patients in terms of humanity and the environment, we can appeal to them based on just cardiovascular disease prevention alone, that eating less meat, eating less dairy can have a tremendous impact on their personal health outcome. But of course, we all know it's more than patients' will. The lack of availability, many of our patients have food insecurity. I'm sure in the UK, but in the US, the price of healthy food is much more expensive than the price of unhealthy foods. There's also a social and cultural norms that are in the way. Marketing and branding, there's been a tremendous discovery about all the sort of behavioral psychological tools that these companies are using to make us become addicted to these fast food and also these sort of snacks. And I think lack of knowledge is, there, but that's not the main reason why people don't eat a healthy diet. I really think it's these other things. And I think it's important for society to help. And this is a reminder about the behavioral economics, that a society, governments, structural changes are needed to make people eat a healthy diet. And, to think about taxes, I know that's a dirty word in America, and I'm sure it is in the UK as well and all across the world. Societies need to do something about sweet beverages, but also these healthy food, making it easier, making our farmers, incentivizing our farmers to do plant instead of, beef and dairy kind of agriculture. Obviously, improving exercise is a huge component of cardiovascular disease prevention. We know that improvement in exercise capacity decreases mortality by 12%. Patients with heart disease decrease their mortality by 8%. The benefit of, exercise, I don't have to tell you, lowers blood pressure, cholesterol, lowers weight, make sure good cholesterol improve. Also, it's tremendously beneficial in terms of endothelial function and glycemic control, and decreases platelet aggregation. And of course, it's so good for mental health. There's even data coming out that not even exercise related, but non-exercise related motions have tremendous benefits. So if you compare patients with active job versus those with sedentary jobs, people with active jobs are, have a decrease in cardiovascular event rates, myocardial infarction specifically, and they are less likely to be hypertensive. Obviously, the 150 minutes of exercise is what's recommended, but really the benefit of the non-exercise related motion cannot be stressed enough. Biking or walking to work, having an active job, parking further away is really important. And when you look at post-COVID, as we shy away from transit use, which means that we're using, cars, personal cars more. It's horrible for the environment, but it's also horrible for cardiovascular disease prevention as well. So if we can't appeal to patients on climate or society basis, we can appeal to them on their personal health interest. That diet and lifestyle changes can have a tremendous impact on cardiovascular disease and can also impact the environment. And it's more than just patients' will or knowledge. And as a physician, as a good member of society, I think it's really important that we continue to focus on what society can do to make it easier for all of our patients. And then I just want to end with this one quote. Oftentimes when I think about climate change, when I think about, structural changes that are needed, I feel overwhelmed. But I think Vincent van Gogh reminds us that great things are done by a series of small things done together. And I urge all of you to join me in encouraging our patients to adopt the sort of less meat, more plant-based lifestyle. Thank you for your attention.
Thank you very much indeed, Dr. Leslie Cho, for that really interesting overview of this topic that's becoming increasingly more topical now that people are reevaluating the diets that they've held for many years, and considering the number of vegan restaurants that are cropping up around here and across the globe. I think it's a particular interest to lots of people. I'm going to take this opportunity now to introduce our two colleagues from down the road at Barts NHS Trust, Dr. Nikhil Ahluwalia and Dr. Krishna Rathod, who will be leading the panel discussion. I know that a number of you have volunteered some questions on the Q&A. Please do keep those coming. There's some really interesting questions in there. And Nicola and Krishna will take us through those with our two speakers now.
Thanks very much, Ali. And once again, thank you so much, Professor Cho and Professor Peters, for your talks on topics that we really don't get to hear enough about. I can see the questions are pouring in. And whilst I might get started with a question for each of you, Krishna will be going through the Q&A. So please do share your questions through there and upvote any questions you really want us to put towards our speakers. So first, starting with Professor Peters, thanks so much once again for your talk. You showed a really interesting national study from Italy that showed the temperature effect. And I was wondering if you knew of any work that had expanded to look at this phenomenon more internationally. Is there any evidence to suggest that this trend extends further and that actually some of the higher incidence of CV disease that we see in hotter countries like China and India could be related to temperature?
So there is actually an international consortium put forward, which now has around 400 communities in multiple countries, and they're including sites in China. And these the study shows both the air pollution effect as well as the heat effect. And so this global I just checked the PubMed before answering this question, and so this is work which is ongoing, but it will be shown soon. And for air pollution, you see a tempering off of the exposure response function at very high concentrations. Nevertheless, I'm very convinced from the data we have looked at in Europe under various conditions that this is really universal.
And do you think it works the other way? And perhaps that might explain why in some of the Scandinavian colder countries there may be a reduced incidence?
Well, there is actually in the so as I have shown for the Augsburg data, I think you need to have come over a certain threshold in heat. So if this heat isn't there, you do not see much. But as now the globe is warming, and even I was really surprised in our very temperate conditions in Augsburg, we were able to see this uplifting and this triggering of myocardial infarction on the hot days, which are on a global scale very modest.
Great, thank you. And Professor Cho, if I can put a question to you, the topic of diets and different diets is all over the news, social media. And it is something that I think if you ask your patients when they come in with heart problems from a secondary prevention perspective, they all want to eat better and they all say it. I was wondering, in your experience, what is the tangible way that any of the healthcare professionals listening on today can enact that advice and convince patients to change behavior, which is such a huge step? And also, is there a subgroup of patients that you think the climate change argument works better in than others?
Well, I mean, I think you're in the cath lab, I can see. That's kind of funny. So I think there are multiple ways to appeal to patients, and I think it's important to appeal to them on all different levels. Obviously, who knows who you have to, try multiple, I think, tactics. The time to talk about dietary changes obviously is before, but most of the time we get to them afterwards. The Mediterranean diet, often people think about this sort of very complex way of thinking about it, but it doesn't have to be. It really has to be, you're eating mostly plant. Your meat is an accent. So the Mediterranean diet, it's a lot of extra virgin cold pressed olive oil, lots of fish, a lot of vegetables and fruits, complex carbohydrate, and then meat, red meat as an accent to your meal. I think it's always important when patients are feeling vulnerable that you try to, give them comfort, but also easy ways to incorporate things like this into their lifestyle. They're not going to do something like this if it's inconvenient, if they can't afford it. There are many free websites that show how you can incorporate Mediterranean diet into your lifestyle, and I think that's really important. I think the shared decision making, this is a term that we like to use in prevention. Shared decision making is when a physician and a patient come to an agreement about what they are, willing to do or can do or excited about doing. That's super critical and important. I really think that as a physician, and you're all, young physicians, some of you are young physicians starting out, it's really important that we try to help our patients through governmental and structural ways to get healthy food at an affordable cost.
Great. And you mentioned organizations. In the UK, we've got a very engaged British Cardiology Society and the Junior Cardiology Association as well. Do you think that what you're seeing in America with the ACC and AHA, do you think they're doing enough to represent cardiologists on this topic, or do you think there's more that they can do?
Well, I mean, I think we can always do more. I think the problem is that, I don't know, I'm sure UK is the same. We're inundated through media, all sorts of crazy dietary schemes. One day peanuts good for you, next day peanuts bad for you. One day, like eating eggs is good, the other day eating eggs is bad. It's so confusing for patients. But who do they trust? They trust their doctors. And it's really important as a physician that that you become sort of educated and aware. Unfortunately, in the US, nutrition counseling is still something that's paid out of pocket for most patients, unless they're diabetic. I don't know if you all have more enlightened ways in the UK. I hope so. But it's really important to try to separate out all the crazy media talks from the truth. And there is the truth, but it's really hard for our patients to sift through some of those things.
Great. Yeah, I agree with that. Krishna, I'm going to hand over to you now if you have any questions from the chat or from yourself.
Thank you very much, Akhil and Ali. And as Ali and Nicola already said, there's talks have been fantastic by Professor Peters and Dr. Cho. So thank you very much. I've just got a question of my own for Professor Peters, if that's okay. You already mentioned that cardiovascular risk has increased in patients who are diabetic, have hypercholesterolemia, in addition to the pollution. Is there any data in differences between men and women in terms of the genders, with differences in risk depending on heat and climate?
This is an interesting question, and I have to admit that I'm not sure. So we are currently looking into differences with respect to air pollution and noise, and indeed find that air pollution has a greater toll in cardiovascular disease in women, and especially in postmenopausal women. And so the women are kind of acquiring the cardiovascular disease later, but then they're often multimorbid. And so this may be an explanation why they then also can be more vulnerable to environmental exposures. But at least none of the big studies have really looked at this separate. And with respect to, good question.
Yeah, I mean, I guess in addition, we know that particularly for us interventional cardiologists, patients who present with heart attacks, women present differently to men, and their treatment pathway is very different for what we found. So I guess it doesn't help by having another risk factor added to that. Just another question from one of our delegates is to Professor Peters. A lot of these studies that you've described, have any of them been carried out in kind of large population areas, maybe somewhere like in China or India, where there's a huge population?
Yes, so there is this multi-center, multi-community study, which indeed also shows the effects of temperature on mortality. And actually so when I showed you the London data, I actually took it out of these multi-center studies. And one of the observations with temperature and heat is that once you have different climates, this minimum temperature shifts. So in hotter areas, the minimum temperature of the lowest value of mortality is higher, whereas in cold temperatures, it kind of moves to lower temperatures. And it's kind of these unusual temperatures which kind of arise also the cardiovascular burden. And this is thought that we have a combination of physiological as well as cultural responses. So in a certain country, you have ways to deal with heat, and you have customs which you learn from your grandparents. And one of the issues with climate change is that those acquired customs and traditions may no longer be true, because if this is shifting, the way the buildings were made, the way the people live, the way they cooled off, may no longer be sustaining their health. So yes, this research is also done by Chinese colleagues who are very active in this area.
Thank you very much. A question for Dr. Cho, if I may. You've described that the rate of meat eating is very high in America and also in the UK and many other countries. If we all start switching to perhaps plant-based diets, vegan or vegetarian diets, is there a risk that the processing of these would contribute to disruption in the climate?
I mean, there is a great study that came out of the Oxford group back in 2018, published in Science, that if we all change to a vegan diet. Now, I'm not foolish enough to think that every person in America, red state, blue state, every state is going to change to a vegan diet. But if we all sort of shifted to a vegan diet, we would have tremendous impact on carbon emission and really can work towards the net zero, in 2050. But the question I think is important is, there are two questions that's really important about changing. I think what we do know is that when we go to a plant-based diet, that we definitely have an impact on cardiovascular disease prevention, and we can have a tremendous impact on climate as well, because we're going to use our land differently and the way we farm a little bit differently. I understand that there are some countries with very enlightened farming, but the land use, I think, is nevertheless a significant issue regardless. And obviously, majority of meat production is not done in those enlightened farming countries. The one I think uncertainty is whether the meat substitute that's currently being touted by various different organizations, whether that actually has the same benefit as just going to a plant-based. These sort of meat substitutes that are currently in vogue. And I don't know. And dietary research takes decades, but the plant, the ones we've had for thousands and tens of thousands of years, we know what those are. And so when patients want to make a change, I tell them, plant, eat mostly what your grandma would recognize as plant, as Michael Pollan says.
Thank you very much. One more question, if I may, from one of our panelists, which I'll change slightly. So the question is essentially says, what are the rates of cardiovascular disease in countries like Japan? But I guess we kind of know the answer to that. But what are there any the links that we have with cardiovascular disease and the climate in countries like the United States and UK, similar to those in countries like Japan, where there's less meat being eaten?
I mean, what we do know that's interesting is that as countries become richer, they tend to start eating more meat. Like China, for example, consumption of meat is more heavily pork-based. I'm not Chinese, I'm Korean, but they're more pork-based. But as you have more meat consumption, you have increase also in cardiovascular disease. So that sort of the plant-based lifestyle of their ancestors then get switched to a more meat-based, more Western diet, and there's an increased risk in cardiac disease. We know from immigration studies, so For example, Japanese that have moved to the US and that have adopted the US lifestyle and also their food pattern, they have a risk of cardiovascular disease that's similar to the Americans, to the Native Americans. Not Native American Indians, but Native Americans. So, I mean, there's excellent data. Really, this is not like about hyping, or this is not about like, what do you call it, auto fiction or whatever. There's really good data that eating more meat increases your risk for cancer, for cardiovascular disease, and that having a more plant-based diet is good all across. Now, there's been lots of controversy about fish. I don't have to tell the UK audience about fish, but the fish and how it's processed and how it's farmed, whether it's wild caught versus farm raised, there's issues there, but it's still better than beef and dairy.
Thank you very much. I have one final question for both Dr. Cho and Professor Peters. What advice would you give healthcare professionals, particularly probably younger healthcare professionals looking to make a difference, and what can they do? Professor Peters perhaps goes first.
So one important issue to my mind is when caring for patients with cardiovascular disease, to count in that they may really be at a higher risk during hot days. So the usual treatments, which otherwise work well, may not work well during this period of time. And so this is like a general advice. And to also learn about the science of modeling the environment, modeling temperatures, and carry this knowledge into the profession and make it one of the components into research, and be vocal about it. So I think the younger generation is changing the way the medical profession and also the cardiologists are thinking about this risk factor, climate change and heat.
Thank you very much. Dr. Cho?
Well, I always say to my fellows and my medical student, our hope's on you. And I really think that as a clinician, you often feel overwhelmed, but we make a difference every day in someone's life. And by appealing if they're not interested in the environment, fine. If they're not interested in their neighbors, fine. But surely they're interested in their own health, and to really think about treating one patient at a time, which can have a tremendous impact. Think about, our shared goals, which is to make each life healthier and better and higher quality. And if that goal can also lead to better things for the environment, I feel like that's a pretty good job, and that's a pretty good calling.
It's very, very sound advice from both of you. Thank you very much for your time. I'll pass you back to Nikhil if he has any further comments.
Yeah, great. Thanks, Krishna. I just want to try and get through some of the questions that have been coming through on the Q&A. I think one interesting topic that's been brought up is what the healthcare professional can do closer to home. And by that, I mean within our own organizations, hospitals and practices can do more to improve their climate footprint. And I think also with regards to the food that we serve inside hospitals and to our staff and patients, do you have any examples of interventions that have been done in your centers on both of these topics? So I'll start with Professor Peters on the climate footprint aspect.
Yeah, so I think indeed the medical sector has great potential to abate greenhouse gas emissions, and there are examples where especially mental health hospitals have really kind of, with patient engagement, with changing their entire food chain, with providing organic food have had tremendous impacts. And there is a very nice example from Germany, from the Münster area, where very impressively, actually this came out of the administrative director of this hospital, who had this vision to make climate education and to really change the way the hospital was run. And he had one of the great successes he explains is also that he has now very easy access to personnel. So while people are competing, people really like to work there with this holistic and climate abating policies.
Great. And Professor Cho, on the diet aspect of the food?
Yes. So the Cleveland Clinic, for many years has been sort of thinking about the diet. And so we have no salt. You can't find salt. If you find salt at our facility, let us know, because somebody brought that in. We try to do so less red meat on our menus. We are very cognizant of where we source our food. So those things have made tremendous impact. We are 12 hospitals, soon to be, I think, 13 with CCF London. So it's a tremendous enterprise, 60,000 people with all those lives, 60,000 people that work for us, with all those lives that we touch. But for our patients, inpatient as well as outpatients and all our cafeterias, we really have tried to be mindful about what we serve and where we source it and things like that. But in general, I think all of us as a voting member of society can do better with our government, with our individual medical societies. It's very, very important. I think educating physicians is super important, because think of the tremendous impact you have on your patients each and every day.
Mm-hmm. Yeah. Thank you. Professor Peters, there's been some questions about how the effect of pollution varies with age, and in particular, whether there's any evidence about the relative impact it has on children and the pediatric patients. Do you have any information on that?
So the children, as well as in utero, we nowadays have evidence for that air pollution impacts the development of an unborn child in utero, that there are substantial effects in early development on the children. Most of the studies are on lung function, on allergies, on metabolic changes. Also, the development of type 1 diabetes is being discussed. And in these areas, it's likely that potentially there are also impacts on based on temperature and heat. So this is why a lot of the global efforts to speak to the effects of climate change are based on studies looking at mortality, at hospital admissions, as myocardial infarctions, as I have shown you. Studies looking at children, you need to basically follow children with finer tools. You need to have birth cohorts, but indeed, in these settings, you also find impacts of both air pollution and high temperatures and heat.
That's great, thank you. And I think a final question to both of you, a topic that's come up and that's close to home is the COP26 conference that's happening later on in the year. Do you have any thoughts on how the medical community can get together and make change here, or do you have a strong message that you think that we should be saying? Professor Cho first.
Well, I think climate change is really something that physicians need to embrace as an issue. And I think that, national societies of medicine, like the American Medical Association, the National Health Services in the UK, and other, global medical societies need to speak up and say, hey, listen, climate change is a medical emergency that's going to happen, and how important it is and critical it is. We think of it in such a different way. We compartmentalize climate change as something that's totally different than our health, which is what it is. And I think it's really important for physicians to speak with one voice.
Great. Professor Peters?
Yeah, so I think the medical societies have a tremendous role, and I think organizing series like this one, as well as the policy briefs, which are produced out of the Lancet Countdown, which is also led by medical societies such as the German Medical Association, I think have a lot of impact, because now I'm an epidemiologist, and I maybe pardon my voice saying this, but they are also regarded as rather conservative outlets. And so I think if these societies speak up, they can have tremendous political power, because they are kind of thought to be rational. This is not the climate movements, not the students going to the streets, but professionals who are part of our societies, who during the pandemic, we now see how much responsibility these members of the society have. And if they kind of argue for climate change, I think they can have tremendous political impact.
Yeah, true. So thank you both so much for taking these questions from our audience and ourselves. I'm just going to hand back to Ali to finish off today.
Thank you, Nikhil, Krishna, and a massive thanks once again to our speakers, Professor Annette Peters and Dr. Leslie Cho, two really thought-provoking talks there, and good there that we've ended on an optimistic note that business as usual is not a foregone conclusion. Climate change is a risk factor for cardiovascular health, but it's a modifiable one. We can do something about it, so we can organise locally and get some solutions sorted. Just a couple of things before we wrap up. Thank you to the audience for chipping in and asking your questions, and for participating in the debate, making it what it is. And special thanks from the RSM to Michael Rapp for providing his generous support to enable free access to this webinar series, which will be going up on YouTube later. On the topic of CBD, I'm going to give you the following disclaimer from the RSM, which I'll read verbatim. To all those watching a recording of this webinar, please remember that CPD points will only be issued to those watching on demand through Zoom. No CPD points will be issued to those who watch the recording on YouTube. Although points or no points, I think that this webinar has hopefully been a really valuable resource that you can point your friends and colleagues towards, so that we can continue the conversation and raise profile of this issue further. The next episode on the series will be on the topic of damaging diets and dangerous water. That's episode 5 on Tuesday, the 11th of May at 6 p.m. Episode will be led by Professor Dame Parveen Kumar and Dr. Lindsay Jacks. The SurveyMonkey link for this session will go around, so please do complete that when you find it in your inbox, and we hope that you can tune in for our next session. Thank you all once again for being with us this evening. Thank you and goodbye.